Good evening, everyone. I thank the Department of Medicine for giving me this opportunity. I'll be dealing with ANCA-associated vasculitis and its kidney involvement. It is one of the most common cause of rapidly progressive glomerulonephritis, and its non-specific presentation or unusual symptoms delay the diagnosis. Immunosuppressive therapy is warranted in almost all patients. Selection of appropriate immunosuppressive therapy is very important. The goal of the therapy is to achieve a rapid, long-standing remission. Going forward, I'll be dealing with three cases. We'll see how we came at the diagnosis and what management we gave and what is the current recommendations. Going to the case one, it is a 56-year-old gentleman from Jharkhand who came to us in June 2019 with on and off fever, malaise, loss of weight, loss of appetite, and vomiting for 6 months. He was having hypertension for last 20 years and on irregular treatment and history of alternative medicine intake for the past 6 months. On examination, except for the pallor, nothing was significant. On investigations, his HP was 8.6, platelet was 6,78,000. Urine analysis was not done on the initial visit. Creatinine was around 3.4 milligram percentage. Ultrasound showed a normal size kidneys. Because there was HP was low and an elderly patient, stool local blood was sent, which came out to be trace positive. And the follow-up visit, repeat creatinine was done, which was showing a 3.1 milligram percentage, but urine analysis was still not sent. So a possibility of a GA malignancy was considered in the background of a low HB and a trace positive stool local blood. He underwent upper GA and lower GA scopies, which came out to be normal. Bone marrow was also done, which was also normal. Infective workup was negative. NCCT thorax and abdomen was done, which was showing focal areas of ground glassing. But patient, after 2 to 3 weeks of OPD visits, he continues to be started becoming sick, and his HP dropped to 7. Platelet was still on the higher side of around 5,50,000 with CRP on the higher side of 75. Creatinine now had gone up to 4.5, and now when urine analysis was sent, it was found that he was having microhematuria and albuminuria. A possibility of a rapidly progressive glomerulonephritis was considered, and ANCA was sent, which turned out to be PR3 ANCA positive. Nephrology was called for a biopsy almost 1 month after he came here. It was turned out to be a typical post-immune crescentic glomerulonephritis with a fibrinoid necrosis. And if you can see that IFTA is around 30%, IFTA signifies interstitial fibrosis and tubular atrophy, which shows the chronicity. Already some chronicity has started to set in, and immunofluorescence was showing negative. That suggesting that there was no immune complex deposition, otherwise called as post-immune. So a diagnosis of a rapidly progressive glomerulonephritis, renal limited PR3 ANCA associated vasculitis was made. Let's go back to the initial investigation slide. You can see the HB was, what were the clues to the diagnosis for ANCA vasculitis? HB was 8.6. There was thrombocytosis was there, which is common in ANCA vasculitis. Our urine analysis was not sent 2 times, despite having a creatinine of 3.4. If we had that urine analysis, we could have avoided this as other procedures like scopies and bone marrows and CT scans. Anyway, we had a diagnosis. We pulsed with methylpred, IV methylpred for 3 doses, followed by he was started on oral prednisolone. For induction regimen, he was started on IV cyclophosphamide, 900 milligram monthly pulses for 6 months. Based on the Cyclops study, of dose of IV cyclophosphamide 15 mg per kg. He didn't require a plasma exchange as his creatinine was around 4 milligram percentage and was not requiring dialysis. At follow-up at 6 months, in January 2020, he was symptomatically better. His HB improved to 12, platelets dropped to 2,72,000. Creatinine was around 1.61. There was no microhematuria. CRP was 3.5, but PR3 ANCA continued to be more than 200. His 24 urine protein was showing around 403 milligram per day. Clinically also was better. Lab wise also there was not disease activity, not much of disease activity except for the PR3 ANCA. So a possibility of a probable irreversible kidney injury with possibility a secondary FSGS setting in was considered. Sometimes PR3 ANCA can be persistently elevated despite adequate induction immunosuppression. He was put on a remission maintenance regimen of IV cyclophosphamide, 900 milligram quarterly pulses for 18 months. I feel that it was pretty higher dose of immunosuppression for a maintenance regimen. And these days, IV cyclophosphamide or oral cyclophosphamide are not given as maintenance immunosuppression. We have better regimens and medicines. So at follow-up, after completing his quarterly pulses for 2 years, after 18 months, he came back with an HB of 11. Creat is now plateaued at 1.6. Continued to have not continued to have, he had a new onset of microscopic hematuria. His proteinuria had increased to 1.7 grams per day, which was previously only 400 milligram. PR3 ANCA continued to be more than 200. He continued to have, he had some constitutional symptoms. So he was referred back to nephrology for consider a rebiopsy. But rebiopsy showed only chronic changes in the biopsy. IFTA interstitial fibrosis tubular atrophy now has increased to 40%. So there was no significant disease activity in the biopsy as well. However, he was put on a maintenance immunosuppression because he was PR3 ANCA positive, continued to be on more than 200 induction, and as well as he is an elderly guy. So he was put on a maintenance immunosuppression of low dose of prednisolone and azathioprine of the same dose mentioned here. At last follow-up around 3 to 4 months back, he came to us. Creatinine was 1.42, planned urine now. There is minimal proteinuria of 0.4 in UP by UC. Is doing well and now continued on a low dose of prednisolone and azathioprine to sustain remission. So what are the take-home essays from the first case? Early recognition, timely referral, and early initiation of immunosuppressive therapy is very important to avoid irreversible kidney injury. Importance of a urine analysis, need to emphasize again and again. Rising ANCA titer, more important than persistently elevated titer. Persistently elevated creatinine and proteinuria indicates irreversible renal damage than active disease. Maintenance immunosuppression. How long to be given? I'll come to that in the coming slides. Let's go to the second case. This is a 49-year-old lady from Vellore who received COVID vaccine in May 2021. 2 weeks later, after the vaccination, she developed some low-grade fever with fleeting multiple joints. No other significant illness in the past. And on clinical examination, she had inflammatory joint swellings involving both large and small joints, and pallor was present. When she came to CMC in July 2021, she had an HB of 8.3. Platelets was 310,000. Creatinine was normal. Urine analysis was showing a microscopic hematuria and albuminuria. However, at this point, this patient was having menstruating, so that was not taken into consideration. But CRP was high and ESR was high. RA factor was also positive, but ANA was negative. In the background of a COVID vaccination, fever, a possibility of a viral fever-induced polyarthritis was considered, and she was treated with NSAIDs, with which fever and joint pain settled. Almost 1 month later, she comes back again with recurrence of the symptoms with new onset of skin lesions here and there, and also some conjunctival congestion for which she was referred to ophthalmology and was found to have uveitis. HB continued to be low on 9.2, creatinine now at increased to 1.9, and urine analysis showed a persistence of a microscopic hematuria and albuminuria. CRP was still high. RA factor, there is a rising titer to 64, but anti-CCP was negative. So a possibility of inflammatory polyarthritis was considered, possible rheumatoid arthritis, and a rise in creatinine was explained by NSAID-induced and AKA, and a prerenal factors was considered. And she was started on HCQ, methotrexate, and sulfasalazine. 2 to 3 weeks later, she comes to emergency with abdominal pain, vomiting, new onset of skin lesions, and worsening of renal functions. Now HB is around 9.2. Creatinine at baseline was at 0.7, gone up to 1.9, and now it is 8.33. And urine continues to show active sediments with proteinuria. CRP has gone up to 121. A possibility of a rapidly progressive glomerulonephritis was considered, and ANCA worsened, which turned out to be PR3 ANCA, which was more than 200. And skin biopsy also showed leukocytoclastic vasculitis. Now nephrology was called for a biopsy, which showed a typical post-immune crescentic glomerulonephritis. Luckily for the patient, she was having only IFTA of 10%, not much of chronicity was there. Acute tubular injury was also there. That explains the rapid rise in creatinine. So let's go back to the investigation again here in this patient also. Initial presentation, she had anemia, creatinine was normal. We got carried away by the she was menstruating history, and CRP ESR was high. In the second visit, she had a rise in creatinine, and microscopic hematuria and albuminuria was still persisting. So we could have considered a possibility of acute nephritic syndrome at that point itself. However, we had a diagnosis finally, and we pulsed her with IV methyl-pred for 3 doses because she had a rapid progression of renal functions with creatinine of more than 5.5. 6 sessions of plasma exchange was done with FFP replacement, and replacement IVIG was also given, and also simultaneously started on oral PRET 1 mg per kg per day, which was continued for 6 weeks and then is being tapered now. And also was started on cyclophosphamide 2 mg per kg, which has to be continued for 3 months. It has to be renal and age dose adjustment has to be made for cyclophosphamide. In last OPD visit, that is around 1 month after the plex, she's off dialysis for last 1 month. Now creatinine is 1.75 milligram percentage. There is some microscopic hematuria which is still persisting, and albuminuria is still there. Maybe too early to say, but still maybe a probable irreversible kidney injury might have set in already in her, and the secondary FSGS might be there. So take home message from the second case also, again, the early importance of early recognition, timely referral, and early initiation of immunosuppressive therapy, the importance of doing an urine analysis for most of the patients, and whether we need to, which patients to be given plasma exchange and which patients not to be given plasma exchange. I'll come to that in the later slides. The selection of the appropriate immunosuppressive therapy, induction immunosuppression is important. And again, the initiation of induction immunosuppression at the earliest possible to avoid irreversible kidney injury. Now coming to the last case, this is a 57-year-old gentleman from Ranipet. He came to us way back in 2015. He also had an unusual presentation of LMN facial palsy followed by uveitis, then rise in creatinine with my active sediments and proteinuria. That turned out to be PR3 ANCA positive vasculitis again. Biopsy showed a crescentic glomerular nephritis. We pulsed him, gave him prednisolone and oral cyclophosphamide and not plasma exchange because he didn't have a severe renal dysfunction. And he was continued on a low dose of prednisolone and azathioprine as maintenance immunosuppression. I'm not interested in the initial phase. I'm interested in his follow. He had a relapse 2 years after the initial presentation in 2017. He had an extra renal relapse when he was continued on prednisolone and azathioprine. He was drug compliant. It was a rhinosinusitis with rising ANCA titers. Biopsy, the biopsy showed a granulomatous inflammation. However, he didn't have any renal manifestations clinically as well as in the urine analysis. His pred and azathioprine dose was increased. He attained remission in between after 6 months of treatment. In 2017 to 2020, he was doing well. Steroids prednisolone was slowly tapered and stopped and was continued on azathioprine monotherapy. June 2020, again, he comes with an extrarenal symptoms of non-specific symptoms. Creatinine again slightly increased to 1.3, started showing some microscopic hematuria, and PR3 ANCA now has gone up to 200, which was last visit it was 65. So it's a clear-cut case of a relapsed PR3 ANCA associated vasculitis. How did we manage this patient at this point of time? Azathioprine was stopped because he relapsed on azathioprine. Prednisolone was restarted at 0.5 mg per kg per day, and we started him on rituximab, 1 gram 2 weeks apart as an induction regimen. Rituximab was considered here because it's not very severe disease, but he had some evidence to suggest a relapse, so rituximab was started in him. Now at follow-up at 6 months, he attained complete remission. Creatinine is 1.08, no active sediments, not much of proteinuria, and the CRP is less than 3.5, and ANCA titers has now come down to 15. Currently, he's on a maintenance rituximab, which he takes every 6 months, 500 mg. We decide on giving the rituximab based on the B cell suppression. We send for a B cell enumeration by flow cytometry. If it's adequately suppressed, we defer rituximab, provided he is not having any clinical evidence or lab evidence of active disease. Now, the best thing about the patient is he's completely off prednisolone, because such patients on rituximab can be kept on off prednisolone on maintenance. They are on maintenance rituximab. In last follow-up around 3 months back, his creatinine is 1.1. UPVUC is only 0.19. His bland urine PR3 ANCA is only 8. So take-home message from this case is regular follow-up and identifying relapses early is very important. Rituximab should be considered as a preferred remission agent for a maintenance regimen. You can consider steroid-free regimen when you're giving rituximab. Consider lifelong immunosuppression in special cases like when the patient is PR3 ANCA, when there is a past history of relapses. Elderly patients should consider lifelong immunosuppression. So coming to the current recommendations, we follow KDIGO guidelines, which is a nephrology guideline forming unit for the nephrologists. They also recommend that even if the presentation is compatible with a small vessel vasculated, vasculitis, you should not delay starting immunosuppressive therapy. Sometimes the biopsy reports or the biopsy may not happen immediately, so do not delay starting immunosuppressive therapy to avoid irreversible kidney injury. Should immediately pulse the patient with IV glucocorticoids 10 to 15 mg per kg per dose, not more than 1 gram per day. And when do you decide to give plasma exchange? Its evidence is based on two trials, mainly the MEPEX trial, which was done in early 20, which was a pretty good study and done in a good number of patients, which favored plasmapheresis. But a recent PEXIVOS trial, which is a larger trial, did not show any benefit in giving plasmapheresis to prevent the progression of end-stage kidney disease or mortality. However, KDIGO continues to recommend plasmapheresis in few scenarios when the creatinine is more than 5.5 or require dialysis during the presentation, or if there is a rapid worsening of renal function, if there is patient is having diffuse alveolar hemorrhage or double positive disease. Double positive disease means patients with both anti-GBM as well as ANCA associated vasculitis. These are the indication for plasmapheresis. So now, what are the agents we can give for remission induction? What is the KDIGO guidelines? After the pulsing with methylprednisolone and plus or minus plasma exchange, we have to start the patients on oral prednisolone 1 mg per kg per day for 4 to 6 weeks, and then we can start tapering. PEXIVOS trial recommends much more earlier tapering of steroids. Showed not much difference between the standard regimen. So we can consider tapering steroids much earlier. Always ANCA-associated vasculitis, you need to give a second immunosuppression. Which immunosuppression? Traditionally, it is always IV cyclophosphamide or oral cyclophosphamide. Both are equally effective based on the cyclo study. However, IV cyclophosphamide has lesser toxicity because the cumulative exposure of cyclophosphamide is lesser, but at a risk of relapse. However, oral cyclophosphamide, the cumulative dose is high and the toxicity will be more, but chance of relapse is less. The dosing of IV cyclophosphamide and oral cyclophosphamide is as given. What is the another option? Another option is we can give rituximab. It's based on the recent RAVE and rituximab trial. But as an injection agent for a severe disease, rituximab may not be an ideal option because in both the studies, in RAVE and rituximab, the drawback of the study was that in both the studies, the average creatinine of the patients enrolled was around 3.5. And in both the study arm as well as the control arm, the patients had received cyclophosphamide. So we cannot say it's a better regimen, better drug for an injection agent. However, the chances of relapse in both the studies, the relapse rate was less in patients who had received rituximab. So it can be considered in some patients who are not much severe presentation or cyclophosphamide is contraindicated. We can consider rituximab. But in our department and even in KDIGO also recommend a combination of doesn't recommend, they tell us to consider both a combination of rituximab and IV cyclophosphamide or oral cyclophosphamide with prednisolone. We these days prefer to give a combination of this so that the dosing of IV cyclophosphamide exposure is also much lesser, and at the same time we are giving rituximab, so the chances of the relapse are also less. So how do you decide on which to be given, rituximab or cyclophosphamide? If it's rituximab is preferred when the patient is much younger, who prefer to preserve their fertility, and frail older adults, and when you want a glucocorticoid sparing regimen, and especially relapsing disease. Both the RAVE and rituximab trial had shown that rituximab in the induction had lesser chances of relapses. So rituximab can be considered there. Cyclophosphamide is preferred when the disease is very severe and those patients who cannot afford rituximab. But you can consider, as we do in our department, you can consider a combination of the three, like rituximab with lesser dose of cyclophosphamide and steroids. What do we give for the maintenance regimen? We have a couple of options. We can give a low dose glucocorticoids with acetoapirin based on the cycastem trial. The regimen is the dosing is 1.5 to 2 mg per kg, and it has to be given minimum of 18 months to 4 years. And ideally, azathioprine before starting, you should go for an TPMT activity if it's possible to send. Other option is rituximab, which can be given at 500 milligram at 6 months, 12 months, and 18 months. and then on demand basis. We can decide on giving, the evidence is from Main-Ritson and the Retazem trial. We can decide on giving rituximab based on the B cell enumeration by flow cytometry. If the B cells are adequately suppressed, you don't have to give, you can defer it, provided there is no evidence of any disease activity from clinical as well as lab evidence. And if you're giving rituximab, you can follow a steroid-free regimen. Other option is methotrexate based on the VESENT trial, but most of our patients, the creatinine is most of the time is creatinine clearance is less than 60, so we don't give methotrexate. MMF is an alternative. 2 grams per day can be given in 2 divided doses. It can be considered when all the above medications are contraindicated or not tolerated. You can consider MMF. MMF is not a good option as an induction agent. So when do you decide to give lifelong immunosuppression? Some factors are granulomatous polyangiitis, PR3 ANCA group, lower serum creatinine at baseline, and more extensive disease, and especially involving the upper respiratory tract. All these patients are high risk of relapse. And past history of relapses is there. ANCA positivity at the end of induction. Despite adequate induction, his ANCA is positive at the end of 6 months of induction therapy. Rise in ANCA titer on follow-up visits, or during the induction phase, the patient couldn't receive adequate induction therapy due to side effects of the drug or due to non-compliance or early glucocorticoid withdrawal. What happened? Such patients are at high risk of relapse. Such patients, we should consider giving a lifelong, even though not lifelong, at least prolonged immunosuppression as maintenance should be considered. So to conclude, early identification, timely referral, and initiate therapy at the earliest possible to avoid irreversible kidney injury. Again and again, I want to emphasize on the importance of urine analysis. Selection of appropriate immunosuppressive therapy should be considered based on the clinical lab evidence and also need to individualize on patient-to-patient basis. And consider rituximab for induction as well as the maintenance to decrease the exposure of the cyclophosphamide. And the need for regular follow-up is very important because our ANCA has very high chance of relapse rate is high. Infection prophylaxis is very important in our population. Thank you.